Okay, let's continue our discussion of healthcare. Excuse me, little frog in the throat today. Music recommendation day, a band called Small Pools. They've been around for a while, really fun pop band. Their song Dreamers is a great song. They're playing actually at a really cool venue called Big Night Live, which is right next to TD Garden, November 12th. And that's definitely a show worth checking out. Okay, so we are going to continue our discussion of healthcare today. We're going to finish up our discussion of optimal health insurance. Remember we talked about optimal health insurance. We talked about basically that it's really optimal cost sharing. What's the right way to share the burden of healthcare spending between insurers and the insured? And we talked about essentially the classic trade-off between consumption smoothing and moral hazard. And we talked about the fact that that would suggest that first dollar coverage was rarely optimal, that you want individuals to bear some of the cost of their healthcare spending, subject to the issue that if they're low income and chronically ill, we're worried they might make inappropriate decisions. And that was sort of where I think the literature was a couple of years ago. But I think there's been a bit of a shift in thinking. And part of the shift in thinking is really driven by what we see in Figure 1510. Figure 1510 shows that there's been a very large rise in actually the use of deductibles on employer plans. If you go back 20 years, very few employer plans had deductibles, and deductibles are fairly small. There's been a large growth in what we call high deductible plans, okay? And today, the average employer plan has a deductible of almost $2,000. Now, part of what's driven this growth in high deductible plans is the introduction of what we call health savings accounts, or HSAs, health savings accounts. Health savings accounts are essentially a kind of savings vehicle that's paired with a high deductible insurance plan. The way it works is if you have an insurance plan where deductible is above a certain level, I think it's $2,000, you can then open up a savings account and put in an amount of money up to that deductible that you can then use to offset your medical spending. Okay, so you can put in money, and the way it works is the money you put in is tax-free. So remember I talked about with employer-sponsored health insurance, one reason that it's popular is because it's tax-free. You're taxed on your wages and not taxed on your premiums. Well, with health savings accounts, you can essentially also not be taxed on your out-of-pocket spending. So the way it works is that MIT has one of these. I have an HSA at Fidelity. And the way it works is I put money in there. That money is not taxed. That's treated as non-taxable income. And as long as I use it to spend on medical care, it's never taxed. Now, if I spend on other things, it'll be taxed eventually. But as long as I put that money aside and use it to spend on medical care, it's never taxed. So essentially, it's a tax-free medical savings account. So essentially, you can think of this as kind of leveling the playing field between insurance and out-of-pocket spending. Before HSAs, there was a bias towards more generous insurance, because if you spent money on insurance, you got a tax break. If you spent money on medical care out of your pocket, you didn't. This is sort of an equalizing tax break. It's sort of saying, okay, now, even if you spend money out of pocket, we'll also give you a tax break. So there's no reason to use your employer insurance to buy a particularly generous plan. You can get the tax break even if you buy a high deductible plan. It's sort of saying, okay, let's give you another tax break to offset the bias from the first tax break. As we'll talk about later in the course, that's not very good government policy in general, but that's what was done. So there's been a massive growth in high deductible plans. And because of that, there's been a massive growth in study of high deductible plans. And the studies have not fared very well for high deductible plans. In the sense that what the studies tend to find is high deductible plans work in that they lower medical spending. They do, if you will, combat the moral hazard of excess medical spending. But they don't do two things we hope they do. First, they don't seem to induce more shopping to find lower cost providers. Remember, the idea of making people pay out of their pocket is not just useless medical care, but to also shop and to find the cheapest medical provider. Because if you're paying the cost of medical care, the idea is you would then shop and find a cheap provider. That doesn't seem to happen. Even people with high deductible plans don't seem to do a particularly good job shopping and finding cheap healthcare options. The second problem is that the evidence suggests that the reduction in medical care that we see under high deductible plans is non-discriminating. That is, people cut back both valuable and not valuable healthcare. The idea of a high deductible plan is something that's really valuable, you'd still get, but something like my knee example, which you don't really need, you wouldn't get. That doesn't seem to be the case. People just seem to get less of everything, including preventive care and highly effective care. And that's worrisome. So we've started to be concerned that maybe the moral hazard effects, benefits of high deductibles might be overstated in terms of people actually not getting care they need. In particular, what's particularly worrisome is a recent study which said it's not even high deductibles. So what this recent study did is they looked at low-income Medicare enrollees who faced a very small copayment on their drugs, $2 or $5, a very small copayment for their drugs. And then they showed that people were more likely to fill their drugs once they got their Social Security checks. Now, you can sort of understand why they have money in the bank, but it's sort of crazy if you think about it. That here's a drug that could save your life, and you don't have the $2 to $5 to pay it till you get your Social Security check. That's certainly worrisome that people might not be taking valuable drugs because of cost sharing. So it's starting to be more and more of a concern that cost sharing could be risking our health. I think it's an area that needs to be studied more. Certainly, it suggests that we want to be very protective of low-income people. This Medicare result suggests that even small copayments for very poor people, in other words, I said first dollar coverage is never optimal. We might have to amend that. This Medicare result may say for very poor people, first dollar coverage may be optimal. They might be willing to live with some moral hazard to make sure they get the drugs they need. But it also says that once again, ideally, we'd want a value-based insurance design, one which says, yeah, but it's not something valuable will make you pay, but it's something valuable won't make you pay. And the question is, can we really get there? Okay. So the bottom line is we're a bit in flux in how the profession is thinking about cost sharing. I think the sort of principle that came out of the Feldstein work in the 70s was you want people to have high deductible plans. I think increasingly we're thinking, well, that's bad, both because poor people don't get the care they need and because sick people might, and because people might not be able to discriminate the care they need versus the care they don't in deciding to delay care or defer care. And so for that reason, we're a little bit more of an ambiguous place on what optimal insurance should look like. Okay, questions about that? All right, so that's what I want to say about optimal insurance. What I want to turn to next is optimal reimbursement. How should we actually pay medical providers? So when I talked about moral hazard, I talked about multiple dimensions of moral hazard. In chapter 12, remember I talked about multiple dimensions of moral hazard. And one dimension of moral hazard is moral hazard effects on providers. Traditionally, in the healthcare system, we have what we call retrospective reimbursement. What that meant was a doctor did something to you, they billed the insurer, and the insurer paid it. If the doctor did two things to you, they billed the insurer twice, and the insurer paid them twice, and so on. What that meant was the more doctors did to you, the more money they made. And there was a concern that this set up very adverse incentives, particularly in an era when patients weren't paying any of the cost. That if you have patients who aren't paying high costs and providers who make more money the more they do to you, the concern is that could lead to an overuse of medical care. That retrospective reimbursement could lead to an overuse of medical care. Because look, even if not because doctors are bad people, but imagine a doctor cares about two things. They care about making you healthy and they care about their income. And let's say there's a treatment that won't hurt you and has an infinitesimal chance of making you better, and they make a bunch of money from it, then they should do it. It's not going to hurt you, and they make money. It's not that they're evil. They're just maximizing utility function, which has your health and their income. So as long as they can make money without hurting you, they'll do it. Okay. So the view was under retrospective reimbursement that doctors were potentially over-treating patients. This is another version of the flat of the curve. The patients were just being over-treated because it was free. They're being over-treated because doctors made more money as they treated them more. And that led to a rise starting in the 1970s of what we call managed care. managed care was essentially a move towards reimbursing providers in new and innovative ways to try to get around the moral hazard of retrospective reimbursement. So the earliest kind of managed care organizations were called PPOs, preferred provider organizations. These were just basically healthcare middlemen. Basically, the way they worked is they'd go to, so the first one was set up by like Hewlett Packard out in California. And somebody went to Hewlett Packard and said, look, if you will tell your employees they can only go to one of 3 hospitals, we will lower your healthcare costs by 25%. I'm making up the numbers. Hewlett Packard said, sure. That same organization went to the hospitals in the area and said, whichever 3 hospitals will give us the lowest price can become the 3 hospitals to get all of Hewlett Packard's employees. And the hospital said, great, we'll give you a low price. So essentially they served as a middleman to do the shopping that people weren't doing. It's hard for people to shop for hospitals, so these organizations essentially shop for them. And they gave some of the money back to employers and kept some. And so this initially worked quite well to basically take a lot of the excess profits out of the hospital sector that are being generated by imperfect competition, by imperfect shopping, by essentially setting up a middleman that was doing the shopping. The problem is that hospitals sort of wised up and said, wait a second, we're Stanford Medical Center. Hewlett Packard's never going to sign up for a plan that doesn't include Stanford Medical Center. Fuck you. We're not giving you a discount. And the PPO suddenly realized they didn't have any power. The hospitals panicked at first, gave them big discounts. That's for like, wait a second, we have more power than we think. No, everyone's Mass General Hospital in their network. That gives enormous power. And so PPOs were successful initially, but then quickly hospitals sort of outsmarted them. That led to the next step in the evolution of managed care, which was HMOs, or health maintenance organizations. The idea of an HMO, of the original HMOs, like Kaiser Permanente out in California, was to essentially integrate the delivery and the insurance of medical care. The way Kaiser works is when you buy insurance from Kaiser, you go to Kaiser doctors and Kaiser hospitals. It's what's called a staff model HMO. Basically, the idea is the same group that insures you also delivers your care, thereby reducing the incentive problem between insurer and provider. Right now, the incentive problem is provider wants to spend as much money as possible. Insurer wants to limit the money they spend. If the provider is the insurer, they can internalize that problem, make it go away. So for example, Kaiser pays its doctors salaries. It doesn't matter how much they treat you, they get a salary. So there's no incentive to overtreat you. So basically the idea was to essentially move away from retrospective reimbursement towards something more like prospective reimbursement, where what you get paid is not based on what you did. Okay, but based on, say, things about the patient, stuff like that. Yeah.
Why wasn't it doctor to pay a salary and not my house?
Well, because in the first case, who would pay them the salary? So when you don't have Kaiser, when I'm a regular doctor and I see patients for Medicare and Medicaid and all these other places, who pays me the salary? It only worked for Kaiser because they were an employee of Kaiser, that the insurer and the doctor were part of the same organization. When doctors are independent and see people from multiple insurers, you can't put them on salary. It wouldn't work. Because who would pay the salary? So basically, that's why doctors are on salary in countries with single payer systems. There's one payer, you can put them on salary. Well, with multiple payers, you can't really put them on a salary because who pays the salary? Yeah.
So what exactly is a hospital? Do doctors get paid by hospital? Or just like
a hospital no, doctors, hospitals are separate medical providers. When a doctor does stuff at a hospital, the insurer pays the hospital and the doctor. Hospitals don't own it. Hospitals are just like parallel to doctors. And the insurers are above them. So in Kaiser, the way it works is you pay your monthly premium. Anyone from California is in Kaiser? What's someone from Kaiser? So the way Kaiser works is you pay them a monthly premium, and then you agree to go to a Kaiser doctor or Kaiser hospital. And those doctors and hospitals are paid an amount which doesn't depend on how much they do to you. So there's none of this incentive to overtreat you. Now, in fact, that turns out to be pretty hard to put together. So mostly what's happening with HMOs is not staff model HMOs, but rather HMOs that are put together, HMOs that are put together by essentially HMOs contracting with a variety of doctors and hospitals. Yeah. Excellent question. So the question is, let me just make one point and I'll come back to that. Most HMOs today are not like Kaiser. The doctors aren't on salary. What most HMOs do is they contract with doctors and hospitals, but they do so prospectively. And what they say is they give them what we call a capitation payment, not to be mixed up with the decapitation payment. Okay, a capitation payment says say you're a pediatrician, every kid that's covered by Blue Cross that's in your practice, you get $200 a month. I don't care what you do to them. You never see them, you get $200 a month. You see them 100 times, you get $200 a month. It is prospective reimbursement because it doesn't matter what you do to the patient. You get the same fixed amount. Okay, and that's the fundamental core of managed care of HMOs, is they pay providers prospectively, not retrospectively. They base them some fixed amount based on who the person is, their age, their gender, things that are wrong with them, and not based on what was done to them. Now that raises the natural concern. Could that go too far? Could you actually move off the flat of the curve and start to actually, in the limit, you make the most money by not treating people? We don't want that either. So it really becomes an empirical question of how did managed care and HMOs do in terms of affecting patients in the US? And the evidence is pretty clear on 3 points. The first point is that there was massive adverse selection. What I mean by that is the people who signed up for HMOs were the people who needed the least health care because they were worried about exactly what this question said. Moreover, HMOs made the most money by signing up the healthiest people because they were just going to pay a flat amount per month. The healthier you were, the more money they make. The healthier you are, the more money they get. So it's two-sided selection. There was the famous saying about the third floor walk-up HMO. If you can make it to the third floor, we'll insure you. The idea being that they didn't want sick people. Or HMOs would literally advertise, like, not quite this blatant, but things like, God, our cancer doctors suck. You know, like, don't come to us if you have cancer. Just trying to basically select out the worst people, because if they're going to pay a fixed amount, if you sign up and you're sick and they're going to pay a fixed amount, then you're a bad deal. So basically, there was adverse selection. But even controlling for adverse selection, it looks like HMOs did lower costs. That prospective reimbursement did bring costs down a lot. That when you reimburse prospectively, spending goes down. And there's no adverse health effects. That is, there's enough other incentives to treat people well, either through patient side moral hazard or other things, that even removing the retrospective incentives did not actually lead providers to deliver too little care. Now, this is on average. There's certainly plenty of stories of HMOs denying people needed care. But on average, there was not an aggregate impact on adverse health, on health. Okay, in fact, you could argue HMOs would make healthcare better, right? Because the doctor follows you more closely, you're part of the same organization, et cetera. And that's what HMOs argue. But the bottom line is, providers spent less and people are no less healthy, which suggests that moving to prospective reimbursement, which is basically where the whole country has moved now, was a positive direction. Okay, yeah.
In other countries which have public health care, what system are they more analogous?
They're analogous to Kaiser. So everyone's on salary. The doctors are all on salary and they don't get paid based on what they do. Now, if you think about it, salary is kind of in between retrospective and prospective. Retrospective is the more you do, the more you get paid. Prospective is the more you do, the less you get paid, the less you make. Salary is kind of in between. Okay. But basically, it seems like across the spectrum, there's enough incentive for doctors to treat you well that even moving to prospective reimbursement is not harming patients' health. Yeah.
If they're on salary and they're making less than during the retrospective case, does that mean there might be less doctors in the future? That's
a great question, which is ultimately, aren't we worried that basically it's a bit like if you think about, you know, why we need to pay drug companies. And someone asked the question, if we cut what we pay drug companies, won't they do less R&D? It's really a supply elasticity question. Obviously, salary won't cause less doctors if salary is high enough. It's just a supply elasticity question. So the question becomes, what's the supply elasticity of doctors? And the answer seems to be that we're nowhere near worrying about not having enough doctors. Okay, other questions? Those are good questions. Other questions? Yeah. So actually, it's very interesting. So there's serious barriers to entry for the medical profession. It's not that the length of medical school is so much longer here. It's that relative to other countries, we have an incredibly long residency and internship program. So actually, people often say, oh, we don't have enough doctors because medical school, there's not enough medical school slots. That's not true at all. We actually have more, we actually can find a job for everyone in medical school. There's plenty of medical school slots. The problem is after medical school, you have to, and your friends have been doctors or whatever, you have to go do a residency and internship at a hospital. We don't have enough slots for that. And that's the constraint in the US. Okay, good questions. Other questions? So that's where on the supply side. So that's basics. That's your sort of basics of health economics. Okay, that's sort of health economics 101. Now I want to come on and talk about the key public policy issues in the government provision of insurance. And to do so, I'm going to do so in 3 steps. I'm going to start by talking about the 2 biggest government programs, Medicaid, which insures the poor, come on guys, and Medicare, which insures the elderly. And then I'm going to talk about healthcare reform and how we deal with everyone else. Okay, and I'll do that over this lecture and the next lecture. Okay, so let's start by talking about Medicaid. And I mentioned this briefly last lecture, but now let's get into some more details about Medicaid and what it is and how it works. Basically, Medicaid, like UI, is a federally mandated state-run program. Every state runs its own Medicaid program, but it's federally mandated. And likewise, the cost is shared with the federal government. There's what's called an FMAP, the federal matching something percentage, federal matching assistance percentage, I don't know what it is, which is basically the share of Medicaid costs paid for by the federal government. So it's at least 50%. And the poorer your state is, the higher the feds pick up. So the feds pay between 77 and 50% of the cost of Medicaid, and states pay the rest. So it's a shared burden with states and the federal government. And the poorer states, the feds pick up a larger share. Basically, now who's eligible for Medicaid? Medicaid basically applies to really several different groups. When it was introduced in the 1960s, this is part of the Great Society under Lyndon Johnson. When Medicaid was introduced, the idea was to give health insurance to single mothers who were getting cash welfare payments. We haven't discussed cash welfare yet, but it's a transfer to our poorest families in society. It's very poor families. Okay, so the idea was to give health insurance for those same very poor families. However, it's dramatically expanded over time, and it's expanded in a couple of ways. One way we're not going to talk about right now, which has been a huge expansion in Medicaid for the poor elderly. This is the place they meet. The poor elderly get Medicare and Medicaid. Medicare covers your acute illness, the hospital. Medicaid covers your long-term care needs, the nursing home. That's really expensive. So in fact, most of the growth of Medicaid spending has been on the elderly. And right now, about between 2/3 and 3/4 of all the Medicaid spending is on the elderly. That's not where the policy discussion is. We'll come back to that. We're going to focus on the remaining 1/4 to 1/3 of Medicare spending, which is on the non-elderly. We'll come back to the elderly piece either later this lecture or next lecture and talk about long-term care. But for right now, we're focusing on acute care, not long-term care, hospitals and doctors and drugs. So we're talking about the non-elderly Medicaid beneficiaries. Like I said, they're originally the poorest of the poor. And then starting in the 1980s, it was expanded for 2 groups, for kids and for pregnant women. To the point where in most states by the year 2000, nationally by the year 2000, every kid and pregnant woman, pregnant woman only for the cost of pregnancy. If she got the flu, she wasn't covered. Just the cost of pregnancy, for the cost of pregnancy. Under 2 times the poverty line was covered. Now, this is always hard to do this because I haven't covered the poverty line yet, because that's the next chapter. But roughly speaking, the poverty line is $25,000 for a family. 2 times the poverty line is probably 80% of median income in the US. So basically for most people below median income, for kids and for women for the expense of pregnancy, they were covered. Okay. But if you weren't a kid or weren't a pregnant woman, the coverage was more like a third of the poverty line. It was much, much lower. So basically a program for the poorest of the poor and for kids and pregnant women. Okay. Now that changed as part of the ACA. One of the major, and turns out probably one of the most important aspects of the ACA was the Medicaid expansions, where the federal government said, we are no longer going to make this a program just for the extreme poor and for kids and pregnant women. It's a program for all the poor. So it expanded Medicaid to everyone in America below 133% of the poverty line. So for a family, it's below about like $32,000. So still poor, but not, it used to be a family below what's close to zero. So essentially Medicaid was converted to an entitlement for all poor and for all poor people in America. Plus you still got the kids and pregnant women are covered higher than that. But that was a massive expansion of the Medicaid program. Okay, was to make it so that it was no longer just the super poor and kids and pregnant women. Now it's basically all the poor and kids and pregnant women who are above that. Okay, so that's eligibility. Now, what does Medicaid cover? Medicaid basically is, I like to call it the best insurance money can't buy. Because Medicaid is more generous than any insurance you'll have in your life except you're on Medicaid. There's no co-payments, no deductibles, everything's covered. Okay, every state covers drugs for free. Many states have dental, some states have vision, but basically no co-payments. Sometimes like $1 co-payment for a drug or something. No co-payments, no deductibles, completely first dollar coverage. So if you get Medicaid, you have completely first dollar coverage, which is in some sense consistent with the view we talked about earlier, that the poor will underuse care if you make them pay anything. So that's sort of consistent with that view. However, on the other hand, providers are paid terribly by the Medicaid program. So the rate at which Medicaid pays providers to see patients is something like a quarter of what private insurance pays. So for many years, until about 10 years ago, a doctor seeing a Medicaid patient in New York got like $15. Okay, it was like $150 for private insurance. So basically, Medicaid systems cover you with very generous insurance, but don't pay doctors well to take it, and doctors don't have to take it. There's nothing like the emergency room law here. If a doctor doesn't want to see you, they don't have to. So sort of a mixed bag. You got great coverage, but it might be hard to find a doctor who would take it. And that was the challenge of Medicaid. Okay. Questions about that? Yeah.
Or Medicaid expansion, wasn't it like charged by the court and like?
Yeah, I'm going to come back to that. Basically, I'll come back to that. Medicaid expansion was in the law was mandatory. The Supreme Court made it voluntary. Those of us who helped write the ACA said, well, big fucking deal. I mean, basically it's a free, if the federal government was paying to give free insurance to people in the states, of course they'll take it. Turned out we understated politics and half the states didn't take it. Now there's still about 12 states that haven't expanded Medicaid. And I'll come back to that later. Yeah.
What's the uptake rate of Medicaid like before the ACA thing? And
Great question. Yeah. So basically, the take-up rate for Medicaid is once again around 2/3. Around 2/3 who were eligible. We're taking it. So there's a lot of, like I said, remember I said the uninsured really in America are focused in two groups. One is the very poor who don't take their Medicaid, and the other is the near poor who are too rich for Medicaid but don't get insurance from their jobs. Oh, and a third group, I should mention, it's non-trivial, which is undocumented immigrants. Poor, non-poor are a large share of the uninsured. Those are sort of the three big groups that make up the uninsured in America. Yeah.
Wait, so why does Medicaid pay the provider so much lower relative to the private insurance?
It's a political decision. It's purely politics, and basically state Medicaid programs. Essentially, I think their view is that, there's a distaste for poor people in many places. I think their view is this is how we're going to keep our budget. Medicaid is, to be fair, Medicaid is the largest and fastest growing part of virtually every state's budget. So to be fair, they're under a lot of budgetary pressure, and the way they deal with it is by paying providers less. If you deal with it by not covering someone's hospitalization, that's on the front page of the newspaper. If you do it by paying a doctor terribly so the doctor won't see anyone, that doesn't make the newspaper. So it's a convenient way to keep your costs under control. Good question. Other questions? Yeah.
Guarantee that doctors would accept.
You can't. I mean, basically, and there's a trade-off. There's clear evidence that the more you pay doctors, the more they take it. Now, even in states that don't pay doctors much, doctors still take it. But this is the supply elasticity question. But supply elasticity, you're not into being a doctor at all, but supply elasticity into the program. And the answer is there's a significant elasticity. The more you pay, the more doctors will see patients. This turned out not to be a huge problem. Most of the country, it's a huge problem in inner cities and in rural areas. In suburban areas, people on Medicaid are fine. But in inner cities and rural areas, there's real access problems for doctors.
Like, I'm a little confused as to like how do they not pay doctors well? Like after the doctor does whatever the doctor does, like but they like charge some amount and
No, they have an amount that they have a scheduled amount they pay. The doctors and bill whatever they want. They say if you see this patient do X, we have what they call a fee schedule. If you see the pay, now they still pay retrospectively, Medicaid. So if you see the patients and do 20 things, you get paid 20 times, but only according to the fee schedule, which is quite low. All right, great question. Okay, yeah.
Is there any evidence that doctors are over-treating people on Medicaid so that they can get some more money?
There is some evidence. There's a lot of evidence of fraudulent behavior by doctors on Medicaid because it's not well monitored. So there's a lot of evidence of fraudulent billing of Medicaid patients. In terms of overuse, it's sort of hard to separate the moral hazard effect from the doctor effect. Because if people use Medicaid too much, we don't know if it's because it's free to them or because the doctor is doing too many things. So it's a little bit hard to disentangle. Good question. Yeah.
Is this at all related to like the whole doctors and what hazard thing? Is this at all related to how a bunch of doctors they start
Well, that's a very different issue. They don't. That's an issue we talked about more in chapter 6. But the bottom line is doctors don't really still prescribe fentanyl. That's not really an issue. They prescribed opioids because I thought they were safe. And then people got hooked on heroin and fentanyl. But the fentanyl is really, at this point, fentanyl that you read about in the papers and come from doctors, synthetic fentanyl, people are getting illegally over the internet. That's the one that's killing people. Doctors prescribe fentanyl is a trivial issue, health-wise. Right? Yeah.
So doctors benefit from different health plans.
Doctor, I'm sorry?
Are doctors paid by different health plans?
Yes. Doctors paid. So if Dr. Hannah sees you, every healthcare plan is a minute they pay her. So if you're on Medicaid, she knows what she get from Medicaid. If you're on Medicare, she knows what she get. Private insurance, she's negotiated a deal with the private insurer. She signed a contract. So Medicare, Medicaid, she has to accept their rate. But private insurers, or not see you, that's fine too. Private insurers, the way it works is Dr. Hannah negotiates a rate with the private insurer. And increasingly what's happening in medical care practices is they're growing and consolidating because traditionally insurers had the upper hand in those negotiations. But if you're now all the doctors in Boston, that gives you an upper hand in negotiation. So the doctors are cartelizing basically, trying to get a better position negotiating with insurers. Yeah.
Is this the whole like paying the doctor's class probably if I guess like the patients are saturated, like there's a lot of patients.
Yeah, no, exactly. It's sort of you can imagine sort of a kinked curve where kind of for a while you can pay doctors less, it doesn't matter. But at some point it starts to get harder to see a doctor. And that's the problem. Yeah.
To my knowledge, Medicaid, like the way it works is like you get a really like basically free plan from a private government, like a.
Okay, so basically that's a great point. I'm going to talk about that in a little bit. It's not really government insurance. At this point, the government contracts with managed care companies to provide it for about 90% of people on Medicaid. I'm going to come back to that in a little bit. All right, good questions. Okay, so let's talk about, there's lots of questions we can ask about Medicaid. You asked a lot of good ones. Let's talk about one particular question, which is how does Medicaid affect health? So for example, the ACA included a big Medicaid expansion. The whole part of the motivation was to improve people's health. Okay, well, once again, first part of the motivation consumption smoothing, we talked about that. It's sort of unambiguous that for a very, very poor population, you can do a lot of consumption smoothing by giving them health insurance. Very poor, very, very poor people don't have a lot of self-insurance to be crowded out. And indeed, there's lots of evidence that when Medicaid was expanded, it dramatically improved the financial protection of consumers. Okay, much less, fewer bankruptcies, much less credit card debt. But that's not sort of surprising. It's sort of intuitively obvious. If you take a population with no money and give them insurance, there'll be consumption smoothing benefits. Okay. The more interesting question is what does it improve their health? Well, there, it's actually interesting. And actually, it's a little diagram I kept with an article I wrote to try to think about that. That's in figure 16.1. Okay. Do we have this chapter 16 handouts? Do we hand those out? There's some here if people don't have them. So figure 16.1 is the sort of mechanics of how expanding Medicaid might impact health. So you begin by saying, look, we're going to make more people eligible for Medicaid. So for example, say everyone below 133% of poverty. At that point, two types of people can then sign up. One is the previously uninsured, can say, great, I want to take it up. But remember, it'll be less than full. Remember, some previously uninsured won't take it up. We talked about take-up barriers, information, stigma, et cetera. But there's another piece we didn't talk about as much, which is some people with insurance will also take it up. As I said at MIT, I pay $8,000 a year for my insurance. If I'm in the suburbs and I know there's doctors that take Medicaid and I won't pay anything and have no cost sharing deductible, I might say, screw it, I'm going to stop taking my insurance, just take Medicaid. That's the crowd out problem that we've discussed about in other contexts. The part of what Medicaid will do is bring uninsured people in, but also cause insured people to drop their private insurance and join. Those two will come together to increase Medicaid coverage. That's step one. Step two is, does Medicaid coverage actually translate to Medicaid utilization? Well, that depends on whether you can see a doctor. Once again, we think it's obvious if you're covered, you get more health care, but it's not entirely obvious when doctors may not want to see you. Step three is, does more medical utilization lead to better health outcomes? Well, that's not all as obvious either. In fact, we've talked a lot the last lecture about how the flat of the curve, and people getting more medical care may not improve their health outcomes. So if you put step 1, 2, 3 together, it's not at all clear that expanding Medicaid is going to improve health outcomes. The last step is the one we care a lot about at economists, which is it a cost-effective way to improve health outcomes? Even if it does it do so cost-effectively? Okay, so that's some of the framework we want to have in mind. Now, to use this framework, there's been a huge literature, of which I've done a lot of work and others as well, essentially using the quasi-experiment that is the Medicaid expansions over time. And both the initial Medicaid expansion in the 70s and 80s and 90s, and the more recent Medicaid expansion under the ACA, which is basically different states have expanded different groups at different times. And that sets up a nice quasi-experiment. In particular, for the expansions in the 80s and 90s, there was enormous variation in some states expanding not at all, some states going for kids up to 3, but not up to 5, some kids up to 5, some states going 100% of poverty line, some states going 173% of the poverty line. Those quasi-experiments run rampant. Everywhere you look, different states are doing different funky things in ways that let you set up lots of cool control groups. Because even within one state, you had different ages and income levels being treated differently. And then those same ages and income levels will be treated differently in the neighboring state. So all the stuff we learned in chapter 3, we saw in chapter 14, it's like run amok here. And I have a sort of simple example in the textbook, but I don't need to go through it. The bottom line is, this is a great framework for doing quasi-experimental analysis, the type we've talked about. And that's a lot of what I did on the older early expansions and more recent literature is done on the ACA expansions. What have we learned? Well, the first thing we've learned is that take-up is relatively modest. Or, I'm sorry, the net sum of step 1 is relatively modest. That is, we estimate that for every person made eligible, or for every 100 people made eligible, only about 25 people join Medicaid. There's a very low marginal take-up rate. I talked about take-up rate of 2/3 before. That's sort of the average take-up rate. Look at the marginal take-up rate when you expand Medicaid, it's fairly low. Now, why is that? Well, partly it's because most of the people you make eligible to expand Medicaid already have private insurance. Even among the near poor, many people have private insurance. So part of the reason why step 1 gives a 0.25 estimate is that if you look at the data, about 2/3 of those made eligible already had insurance. So for example, if there was no crowd out, then the right estimate of take-up would be 25 over 33, which would be about what we typically think of as take-up rate, about 2/3 take-up rate. So the question is, how big is crowd out? How much of the people who end up on Medicaid, when you expand it, actually formerly had private health insurance? And the answer is crowd out looks fairly sizable. Now, there's different ways to define crowd out. You're not responsible for the number. But roughly speaking, at the end of the day, for every 2 people added to Medicaid, only one person used to be uninsured. Crowd out's about 50%. There are 50% of the people who end up being added to Medicaid would have otherwise had private health insurance. It's a pretty big number. Yeah, question.
Couldn't you just prevent that by like adding like, oh, if you have private insurance, you couldn't get Medicaid?
Why can't you do that? Not politics, yeah.
Why do you get private insurance?
Yeah. I mean, I just dropped my private insurance and said I don't have private insurance. It's not tattooed on your forehead that you have insurance. It's a choice. So it just wouldn't get it. Indeed, it's quite interesting. I was part of a very heated academic debate. You know, these things get very intense because I was sort of the leader of the camp that said crowd out was quite large. And other camps said, well, look, if you look at people with insurance, not many of them drop it to go on Medicaid, so I must be wrong. But what they missed is many people weren't getting insurance because Medicaid was available. That's exactly the point. So you end up with a fairly large crowd out, and that makes you concerned that, gee, maybe what we're doing is not providing people that much help. Maybe we're just getting people off private insurance into public insurance. So that leads us to step 2. Did it actually increase utilization? And the answer is it did. Even though a lot of people were crowded out, there was a dramatic increase in utilization, both from the Medicaid expansions in the 80s and 90s and from the more recent Medicaid expansions. Massive increase in utilization over time. And then finally, the question is, did that increase utilization actually improve health? Yeah, question.
Like I'm assuming the private insurance plans that these low-income people were on before Medicaid were probably not first on the population, a lot like less.
It's a great question that I'm very glib about, which is, let's say I go from a plan with a $5,000 deductible to one with no deductible. That's called crowd out, but I'm getting a lot more financial protection than I used to be. So the definition of crowd out is sort of tricky. Crowd out really should be defined as how much protection are people giving up to get on Medicaid, and that's a harder thing to measure. It's a great point. In some sense, I talk about crowd out in a very pejorative way, like, oh, that's a waste if they're just on private insurance. But it's not really pejorative. It's really an income transfer. You're really saying to those people, look, you don't have to pay for your private insurance anymore. We'll not give you the money. But it's not an efficiency gain. It's just an income transfer. Okay. All right. So, and then what about health? Well, basically, this is a fascinating lesson in methodology, which is that there was a large body of literature before the Affordable Care Act, to which I contributed, so I'm biased, saying that when you expand Medicaid, health improves significantly. So for example, some work I did in the 90s found that the infant mortality rates fell by on the order of about 10% when you expanded Medicaid to babies. So big effects of expanding Medicaid. And that was sort of the consensus. Then around the same time as the Affordable Care Act, we had actually by accident another major health insurance experiment, which has been called the Oregon Health Insurance Experiment. Now, unlike RAND, this was not set up on purpose, but by accident. What happened was the state of Oregon had 10,000 new slots to give people health insurance. So they said, well, we know more than 10,000 people qualify, so we're just going to randomly have a lottery. We'll let people apply, and we'll randomly select who gets insurance. Well, that's an experiment. That's perfect research setup. So 100,000 people applied, 10,000 got chosen, and there began a huge project led by my colleague Emil Finkelstein, but I was also involved, to evaluate this experiment. And the findings were quite striking. We found that people who got Medicaid used a lot more care, just like we thought. But we didn't find major improvements in health, in physical health. There were massive improvements in mental health. Massive improvements in mental health. In fact, almost too big to be believable. Within 6 months of getting insurance, depression had fallen by 30%, which is sort of unheard of. Which leads us to conclude that it's not about medical intervention. It's about getting out from under the stress of being uninsured. That a lot of what insurance is doing, we talk about insurance as preventing you against financial catastrophe. We don't talk about insurance protecting you against anxiety. That a lot of these people were anxious and depressed because they knew if they got hit by a car, they'd go bankrupt. Now that wasn't true, and so they felt better. So mental health improved dramatically. Physical health, there wasn't a real measured improvement in physical health. And that led a lot of people to say, wait a second, maybe all this old evidence was wrong. Maybe the Medicaid expansion of the Affordable Care Act won't actually improve health. There's a lot of concern about that. Well, now we have the Medicaid expansions under the Affordable Care Act, and we can study them. And we can actually ask, okay, well now let's revisit that old literature with the current quasi experiments and ask what happens when we expand Medicaid in some states and not others, because I said some states turned it down. And the evidence is clear that it dramatically improved health. So what happened was there are two very important studies. One study literally just put together the largest data set ever, 4 million people made eligible for Medicaid and looked at what happened to mortality and found that mortality fell significantly when people were made eligible for Medicaid. Another study was super cool. I can't believe they thought of this. So under the Affordable Care Act, we'll talk about next time, there was an individual mandate. The individual mandate said you had to report on your taxes whether you had health insurance. What the federal government did after the first year of the ACA was send reminders to people who reported on their taxes and didn't have health insurance to say, hey, you bet, remember, you're going to get penalized if you don't have health insurance. But they didn't send reminders to everyone. They had a holdout group. They made an experiment. They sent reminders to some people and other people. And they followed them up, and they found that the people they sent reminders to were more likely to go get insurance and less likely to die. That's a pretty awesome experiment. That basically by reminding people them to buy more insurance, you actually save their lives. So actually at the end of the day, we're sort of back to thinking insurance matters a lot for health. And what was wrong with the Oregon health insurance experiment? Probably the problem was the samples were too small or the period of following was too short. But that really, we think if you look at real policy changes, significant increase in health insurance cause improvements in health. Yeah.
People who didn't get reminded, do they still get penalized?
Yes. Okay. So basically, that's sort of where we are. What about, let me make two other points. First of all, you might be saying, wait a second. You showed us this flat of the curve, and you said we're on the flat of the curve. How come Medicaid improved health? We're on the flat of the curve. Do you still have the chapter 15 handout? Do you guys still have it? If you go back to figure 15.8, okay, which is the flat of the curve figure, if you just remember it. Like, you know what? It's not that complicated figure. I can't draw it. Okay, so we've got our flat of the curve here, right? We've got our curve, and we've got, you know, the first, you know, bit of medical spending is very effective, and then it becomes less effective. Okay, we talked about the fact that the evidence was when we moved along this segment, people didn't get any healthier. But that's not what the Medicaid expansions do. They move people from here to here. So it didn't, the fact that made people healthier is not inconsistent with the flat of the curve. It's an average versus marginal. The marginal change in generosity when you're very generous doesn't seem to matter. But giving people insurance does matter. Now, could you take Medicaid and make it slightly less generous? Probably. Okay. But the bottom line is this exactly traces out the curve. The fact that people from zero to insurance massively improves their health. But once they're insured, changing the generosity insurance doesn't change their health much, is exactly what the flat of the curve would predict. So that's point one. Point two is, look, we still remember vividly chapter 8, and we care about is not saving lives, but what the cost of saving lives is. How cost effective was this? And the answer is very cost effective. The estimates are that you could save lives, you could save babies' lives at about $1 million a pop. Now, $1 million is a lot of money, but that's kind of by most estimates the cost of a life worth it. Now we get some thorny ethical issues about how do you apply cost of life estimates to newborns. That's, you know, if you want to really ruin a cocktail party, you can start discussing that. Like, you know, low replacement value, you could really be mean. Okay. But basically, we think that like saving a baby's life for $1 million is a pretty damn good deal. Okay. And so basically, it's pretty cost effective. All right. Questions about that? Okay. That's what I want to say about Medicaid. Now let's go on and talk about Medicare, which is insurance for the, there you go. Come on, guys. Okay, Medicare. How does Medicare work? Medicare is a federal program. No significant state role. The federal program, you become eligible by having worked for 10 years and turning age 65, or being married to someone who worked for 10 years, turned age 65. Okay? It is a program where once you're insured, for most people on Medicare, they have a traditional form of insurance where basically Doctors can decide whether to accept Medicare or not. If they accept Medicare, they get paid certain rates, which are laid out by Medicare. And you can go to any doctor you want that accepts Medicare, which is almost every doctor. Now, Medicare is really 3 different programs. It's really 4 different programs, actually. The first is Medicare Part A. Part A is hospital care, roughly speaking. If you want more details, you can look at more details, but this gives you a rough breakdown. Part A is hospital. The hospital part of Medicare is what your payroll tax pays for. Your Medicaid payroll tax pays for the hospital part of Medicare. But despite that, there is significant cost sharing. There's a significant deductible of about $1,500 if you go to the hospital. So it's a pretty high deductible if you go to the hospital. And if you stay longer, it gets bigger. Part B is docs, roughly speaking. That is not covered by the FICA tax. That is something people actually have to sign up for. So when you turn 65, they say, would you like Medicare Part B? Almost everyone says yes, because it's heavily subsidized. The US government pays 75% of the costs, and people pay 25% of the costs of Medicare Part B, and like 98% of seniors sign up for it. But it is a voluntary program. It's paid jointly out of general revenues by the federal government, and people pay the other 25%. So the Medicare Part B premium. Importantly, Medicare Part B covers docs with an uncapped 10% coinsurance. What that means, if you go to the doctor and spend $100,000 a year, you owe $10,000. You spend $1 million, you owe $100,000. Unlimited 10% coinsurance at the doctor. So significant cost sharing here. Big deductible in the hospital, big potential liability for the doctor. We're going to come back to that. The third program is Medicare Part D. That's drugs. That's a new program that was introduced in 2003. That covers drugs under Medicare. And I want to spend a few minutes talking about the Medicare drug program. So basically, when Medicare was set up, it did not cover outpatient drugs. Because in 1965, any drug that was the only thing you get over the counter was Tylenol. And it was expensive, you got in the hospital. But over time, of course, more and more expensive drugs became available at pharmacies. And in fact, by the late 1990s, elders spent more on drugs out of pocket than they spent on all their medical care in 1965. Okay, drugs are becoming a big burden, to become a political hot button issue. Say we need to cover prescription drugs for the elderly, especially as they vote in high numbers. But there was a big debate over how to do this. Democrats said, well, look, it's easy. We'll just add a Part D to Medicare and it'll operate like Part A and B. The government will buy the drugs and give them to you. Just like the government pays for doctor service, the government will pay for drugs. The government will negotiate deals with the drug manufacturers. They'll buy just like they negotiate, set prices for doctors, set prices for drugs. They'll buy them and then you'll get them. Republicans said, no, we don't like that. We think we should have a new model, which is that people should buy private drug insurance that's subsidized by the government. People should, instead of having the government provide the drugs, we're going to have private drug insurers provide the drugs, and the government will then pay the private drug insurers to do so. Now, it's kind of weird. You might think, like, why the hell do that? But the argument is exactly the argument that was raised earlier that we'll talk more about, which is that, gee, if you have the government provide the drugs, the government will negotiate low drug prices and will drive the drug companies out of business. They'll stop doing R&D, cats and dogs living together, horrible things will happen. Okay? So basically the view was we can't have the government provide the drugs because they'll negotiate prices that are too low. We need the private sector to do it. But the private sector was a famous hearing. Republicans said, we think private insurers should insure people for drugs. Private insurers came to Capitol Hill and said, we don't want to do that because it's going to be huge adverse selection. If you let people choose whether they want drug coverage, we're going to adversely select it against. So the Republicans said, well, what if we pay most of the costs, just have you sort of administer it? And so that was the debate between a Democratic proposal to basically add a drug benefit to Medicare in the same way Part A and B work, and Republican proposal have a fundamentally new approach, which is essentially government paid, privately delivered drug coverage. The Republican approach won. And that's what we set up. And for the first time in our country's history, but not the last, we set up well, not the first time, but it really was a really shot across the bow of the way to think about insurance in America, which was really the precursor of the ACA exchanges, which is instead of the government providing the insurer as a monopoly, the government would contract with private insurers to provide the benefit. And that's what the ACA did. That's what Part D did. Did it work? Well, the evidence is mixed. Initially, the evidence is mixed because we don't know what price the government would have gotten. So certainly relative to what we thought Part D was going to cost, it came in well below budget. The private insurers did better than we thought at getting the cost of drugs down. We don't know is how well the government would have done. So it's sort of hard to know whether it ended up being more efficient to have the private sector do it or the government do it. Now, as we mentioned, under the Inflation Reduction Act, we have for the first time regulation of drug prices in the US. Okay, we have that for the first time. And those regulation of drug prices under Medicare Part D, for the 10 most expensive drugs, the government will regulate their price. And so we'll see what happens. But that was a real battle that took many, many decades. And so this law ended up with the private delivery model, which was a real, I can't overemphasize what a fundamental change that was in the way the government delivered social insurance in America. That was a real change in the way the government really carried out its social insurance programs. Now, the really interesting part of Part D was the cost sharing under Part D. So this is what the government did. It said, look, every private insurer has to cover a minimal generosity. If you want to cover more than that, you can and charge higher premiums. But every private insurer has to cover at least the following. And here's how it worked. Okay, so the way it worked was, so here is your drug spending, and here is your co-insurance rate. And here's how the schedule worked. For the first $250, there was a deductible. So up to $250, you paid 100% co-insurance. Deductible is 100% co-insurance, right? Once you got beyond 250, it dropped to 25%. You paid a 25% co-insurance, and the insurer picked up the other 75%. Okay, so that's sort of a pretty standard, consistent with Feldstein's principles. For the initial spending is a lot of moral hazard. You want a high co-insurance rate, you drop the co-insurance rate, and spending goes up. But then something funky happened. Okay, until you got to 3,600, this stayed in place. Then at 3,600, it went back to 100% co-insurance till you got to about 5,100 or 5,500, I think, when it dropped to zero. This was called the donut hole, which was this period where people who spent more actually ended up having a higher co-insurance. Now, this is completely inconsistent with what we learned about optimal insurance. There is no reason why you would want the co-insurance rate to jump up when you spent more money. People are less able to self-insure. The moral hazard is going to be smaller when you're buying very expensive drugs, etc. So why did they do this? Any ideas? I'll give you a hint. Superimpose on this graph the distribution of drug expenditures and the distribution of senior voters. Think about two distributions on that graph. The distribution of drug expenditures and the distribution of senior voters. And how does comparing those two distributions give you a hint about why they set it up that way? Well, give me a hint. The distribution of senior voters is a normal distribution. Okay, yeah.
I guess maybe senior voters only care about like the middle range or something.
Exactly. Most senior voters are below here. 90% of voters are below there. But 50% of expenditures are above there. So it's terrible insurance, but it's vote maximizing. The optimal insurance would have been something like maybe $1,000 deductible and then dropped to 25%. But then you would have pissed off all these people with you $250 and $1,000. So to make sure they can make as many people happy for a given budget, they screwed the people who need the most protection, which is just an awful victory of politics over economics. But it's a good lesson about the role of politics over economics. Fortunately, in the Affordable Care Act, we got rid of this. And now it looks like this. The Affordable Care Act filled in the donut hole and said all insurers have to have a 25% co-insurance. or, you know, in that range. Okay. So that's how Medicare works. Questions about that, about Medicare? Okay, what I want to talk about Medicare, with Medicaid, I mean, obviously with both these programs, I could talk forever. With Medicaid, I focus on the effect on health. With Medicare, I want to focus on the effect on costs. Medicare is a great story because in 1965, Medicare was proposed. There was no congressional budget office. And Lyndon Johnson said, his administration said, we think Medicare will cost X. I don't know where the hell they pulled the number from, but basically within, Medicare went from costing $64 million in 1966, $64 million in 66 to $32 billion in 1980. And over 14 years, there was a 2,000, 20,000, whatever it is, percentage growth. It grew 20 times, 20-fold in 14 years. Okay, because basically Johnson lied about how much it was going to cost. He knew it was going to cost more, but he wanted it passed. And there's no CBO to keep him honest. So suddenly we reached the end of the 1970s and Medicare's gotten out of control. And the US government decides we do something that could try to control the cost of Medicare. And they did two different things which offer really interesting lessons for health policy. The first thing they did was they moved Medicare from what Medicare hospitals, from what had been a retrospective system to a prospective system. They introduced something called the Prospective Payment System, PPS. Before 1983, Medicare hospitals reimbursed retrospectively. You did a surgery, you billed the government. In 1983, they introduced the Prospective Payment System. The way that worked was the government paid you a fixed amount based on how sick the patient was coming in the hospital. Essentially what the government did is they took all the diagnosis codes in the world, there's like 10,000. They collapsed them into 450 what's called diagnosis-related groups. So basically categories of diagnoses that are related to each other, like heart conditions or broken bones or whatever. And then they said, we're going to pay you a fixed amount per DRG, per patient. So a patient comes in with a broken arm, you get this much. If he stays 3 months and costs you $2 billion, tough shit. You get this much. Purely prospective reimbursement based on how sick the patient was coming in. Okay, a radical change. What effect did it have? Well, it had an enormous effect immediately, the prospective payment system. The average length of hospital stay for elderly patients fell from 9.7 to 8.4 days in 1 year. Okay. If you look, for example, there was a 15% drop in admission to intensive care units, and there was an enormous reduction in treatment intensity. Yet, despite that, elders were in no worse health. It looked like basically there was a huge amount of flat of the curve going on. They put this system in, dramatic reduction in healthcare use among the elderly in hospitals, no worse health for the elderly, which is exactly consistent with the fact we're overpaying hospitals before with the retrospective system, which is cool. The problem is, after a few years, healthcare costs started growing rapidly again, even though the prospective system was in place. The problem was that it's very hard to outsmart healthcare providers. In particular, if you're a healthcare provider and you're faced with the system, what are some things you might choose to do? Yeah. You might report people being sicker than they are. In the year after the DRG came in the year after the system came in, I forget the fact, something like if you believe data reported by hospitals, the elderly in hospitals in America got 20% sicker in 1 year. Now that didn't happen. They just realized that they could do what is called DRG creep, which is they could simply code guys as sicker than they were and make money. Now, in some cases, this is extreme and it entered the range of fraudulent. I mean, it's always fraudulent, but sometimes it's a judgment call, right? Before, remember, there was no incentive. Let's say I came in, I had a broken arm and a heart attack. You just wrote down broken arm if that's what came up first, because who cared? Now you write down heart attack because that gets paid more. That's just honest. That's not fraudulent. But there's clearly fraudulent cases. So for example, in 1995, Columbia Cedars Sinai Medical Center in Miami Columbus Cedars Medical Center, Miami, coded 93% of their Medicare cases with respiratory illness as complex, which has a reimbursement of $5,700, and only 7% as not complex, which is reimbursed at $1,700. Meanwhile, a different hospital across the street had only 28% of the cases being complex. There's all sorts of cases of basically fraudulent behavior of people trying to change this. So that's one problem. The other problem is that the DRGs themselves were not fully prospective, because some of the DRG definitions included in them what was done to you. So for example, if someone has cardiac, if someone comes in with cardiac arrest unexplained, they get $5,000. But if they come in with cardiac arrest and get a coronary bypass, they get $33,000. So basically that's retrospective reimbursement. That's not prospective. We're not paying you the same based on what you come in, paying you based on what gets done to you. Now the idea is, well, someone needs coronary bypass must be sicker, so you should pay him more. But you're basing on what the provider did. So that's retrospective again. So that's another problem they ran into. Another problem they ran into. So anyway, the bottom line is it's very hard to outsmart healthcare providers. And such a system, which is not a truly universal like Kaiser, which just said, look, we're paying you a salary. Anytime you try to set up a kind of reimbursed system like this, you have to worry about the various holes that providers can poke in it to try to get around it. The bottom line is overall PPS worked. It lowered healthcare costs, but not nearly as much as we might have hoped because of all these various tactics that did. Another tactic, what's another thing you do? Remember, you get paid per admission. So hospitals started discharging people and immediately readmitting them. So let's say I come in with a certain DRG. You discharge me, readmit me in the same DRG. I get paid twice. Okay, so there's lots of things hospitals could do. Try to around. They can try to whack them all and get at them. For example, Medicare put in a program which penalized readmissions. You can try to whack a mole on them, but it turns out to be hard. Because if someone's financial interest in outsmarting the system, they'll probably figure out a way to do so to some extent. It's not saying PPS didn't work. It's saying to some extent it was undone by some of these changes. Okay, questions about that? So that was one approach to try to control healthcare costs, is prospective reimbursement. The other approach, and someone mentioned this already, was to move government healthcare to managed care, to Medicare managed care. That was to say, look, we know that these HMOs have the right incentives. They align the incentives of insurers and doctors. So let's just contract out our Medicare people and just say, if you have a Medicare HMO, we'll pay you a flat amount. You take people, then you bear all the risk. So instead of the government trying to figure out how to reimburse, they said, look, I know the average 65-year-old costs $5,000. If you are willing to take a 65-year-old, I'll write you a check for $5,000 and I'm off the hook. That's the average. My costs stay the same. You bear the risk. And so Medicare managed care was introduced starting in 1985. And Medicare managed care has really taken off. It's currently in the figure 16.3. It was currently at about 23% of enrollment. It's now up to about 33% of enrollment. About 33% of people are Medicare managed care plans. What does it mean to be in a Medicare managed care plan? What it means is essentially, it's like you have private insurance. You sign up for, say, Aetna's Medicare Blue option plus extra special Joe, whatever it's called. Okay? You sign up for that. What it means is they then essentially handle all your medical care. You're not really dealing with Medicare anymore at all. But as a managed care organization, what they can do is they can manage your care. They can, for example, limit where you go to the doctor. Medicare, the rest of Medicare, the other 2/3 is called fee-for-service Medicare. Fee-for-service Medicare, that's the non-managed care part. That's the other 2/3. You can go to any doctor and take Medicare, and that doctor can do whatever the hell they want to you, and there's very little oversight. With managed care, it's managed. They keep an eye on the doctors, make sure they don't overtreat you, and they reimburse them prospectively, try to keep them overtreating you, and they limit who you can go see, so they only sign up the cheapest doctors. Essentially, there's a trait. So the question is, why does any elder ever sign up for this? Seems like fee-for-service is a better deal. The answer is they also cover all your out-of-pocket costs. So if you go back to table, where's that? Where it's talking about Medicare, table 16.2, and you look at Medicare, you see that there's big deductibles and co-payments for hospitals and for doctors. Okay. So basically, the bottom line is Medicare is not very generous insurance compared to private insurance. So what managed care says is, look, we will cover all your co-payments and deductibles and co-insurance. In return, you're going to let us manage your care, limit which doctors you can go to, keep an eye on your doctors, et cetera. And that's the trade-off. And about a third of people on Medicare have decided that trade-off's worth it and growing every day. So the question is that, what has that done? Okay. Well, basically, well, the first question is, that's all well and good. But how do you decide how much to pay these managed care agencies? Now, you could just pay them the average cost you're paying for people on Medicare, but then you don't save any money. So the government said is, look, we're going to pay you 95% of what some would cost if they're on fee-for-service Medicaid. So for example, you sign up a 65-year-old. We'll take the average 65-year-old on fee-for-service Medicaid, the other 2/3. We'll take 95% of that and pay you that. And then the government saves 5%. And you can save money if you're more efficient. Okay, seems to make sense. Except I forgot one thing, which is that people choose whether to enroll in managed care. And it's not the average person, it's the healthiest person. And that caused an adverse selection, which means the government loses money, even though they pay 95%. To see why, let's go to figure 16.4. I'm going to go through this fairly quickly. It's really about the intuition, not the math. Let's say that under we initially start with traditional Medicare with no HMOs. Let's say there's 3 groups of people, 100 people each of 3 groups. One group costs $1,000, one group costs $2,000, one group costs $3,000. So in that case, the average cost of someone on Medicaid is $2,000, and the total cost of government is $600,000. Now the government says you can sign up for Medicare managed care. Well, who signs up? The sickest guys don't sign up because they don't want to have their doctor choice limited. The healthiest guys sign up in large numbers. Let's say 30 of them switch over. And the less healthy guys and the medium guys, let's say 15 of them switch over. Well, now, what is the average cost of those left on Medicare? It's gone up. Why has it gone up? Because the healthiest people have left. So now you're not paying the managed care company 95% of 2000, you're paying them 95% of 2018. What does the average person cost the HMO? Way cheaper than that. It's only the healthiest people. They only pay $13.33 per person. So you have just delivered massive profits to the managed care organization. You're paying them 95% of 2118 for someone who costs on average $13.33 to insure. As a result, government costs have gone up and managed care organizations make shitload of money. Shitloads of money. So this is adverse selection in action. Okay, it seemed like, sure, we'll save money, pay 95%, but we forgot it's 95% an average, but they're not enrolling the average person, enrolling the healthiest person. So managed care companies took off. They made huge amounts of money. Well, the government got wise to this and they said, well, this is ridiculous. We know how to solve it. We'll pay you 90% of the average cost. Well, as you can imagine, that didn't work. Okay, because then they just said, well, we'll just make sure we only have the really healthy people to make money. But what it did do is some managed care companies said, you know what, at 90%, we can't make as much money, we're dropping out. So the government went to 90%. So if you look at the graph of managed care over time, there was this huge growth, figure 16.3, huge growth till about 2000 and a big drop off. What happened there was the government cut from 95 to 90. And a bunch of managed care companies said, yeah, there's some adverse selection, but not enough to make money at 90. It's not as extreme as this example. We're out. Well, that's not a problem. The problem is politically, people started to like managed care and they said, that's ridiculous. You can't pay them so little, they'll leave the program. So as part of the same wonderful bill that gave us the donut hole, the Bush administration, its wisdom, the George W. Bush administration, decided they would pay managed care companies 118% of the average cost of someone on Medicare. Now, the question is, how can you save money as a government if you pay a private company 118% of what you're paying? And the answer is you can't. It was just because people forgot the goal of this program. The goal of this program was to save money, not to get people in managed care. But elders like the program because they didn't have to pay any cost sharing. So make the elderly voters happy, they essentially undercut the entire reason for the program. And and these insurance companies made massive money. Insurance companies, most of the profits that US insurance companies have made in the last 2 decades has been on managed care for Medicare. It's a huge profit center. Now, the Affordable Care Act, part of how we paid for the Affordable Care Act, about a quarter of the revenue came from cutting this rate. But we only cut it down to 100%. Because even that was a huge political lift. Okay, so this is still an enormous profit center for managed care, for insurance companies, these Medicare Advantage plans. Because the bottom line is, it's hard not to reimburse them. Now, in principle, we do know how we can reimburse them. How could we set this up in a way to make sure that the government got the surplus rather than the managed care companies get the surplus? What could we do? Yeah. Oh, that still wouldn't help. Even if I gave 90, look at my example, even if I use 95% of 2000, I'd still overpay them. That help a little bit. There's 2 problems. One is the average goes up. The other is their costs are way lower. That would help with the first problem, not the second problem. And so they get a lot of surplus because they're getting that difference. How can the government get that surplus? Come on, you guys are smart. You're the government. The managed care companies are making all this money because you're overpaying them relative to what it really costs. What could you do? What would 1401 say? Yeah.
Figure out how much it actually costs them and pay that.
Well, that is impossible. Let's say you have imperfect information. Yeah. Well, but you would not have taxed them. What 1401 say? What do we do? What causes efficiency in markets? Yeah. Get some competition. Set up an exchange. Make them compete. And then only pay what the lowest cost one charges. Let the market reveal what the true cost is. Rather than paying some artificial administrative set number, let the market tell you. And politically, we've been unable to get that done. It's a clear answer. There's nothing wrong with Medicare Advantage. In fact, if you look at the evidence of Medicare Advantage, it's actually done an incredibly good job at lowering costs without hurting patient health. So basically, Medicare Advantage, the good news about Medicare Advantage is managed care is working. If you look at the effect of people going to Medicare Advantage relative to traditional Medicare, their costs go down dramatically, their health is no worse. We have lots of good papers. I have one cool paper where I looked at counties where Medicare Advantage plans exited. So you look at what happened with exogenous shocks. Costs, when the Medicare Advantage plans exited, costs went way up, but patients were no healthier. So the good news is managing care works. It's better to manage. Managed care is a more efficient way to deliver care. It lowers costs without risking patient health. Okay, so it is a better program than fee for service. The bad news is we're overpaying for it. We could have our cake and eat it too. If we simply played the Medicare Advantage plans, if we had a competitive exchange. And so we're only going to pay what the lowest one charges. The problem is a bunch of Medicare Advantage plans would then leave and people get upset. But we know the right answer. The right answer is we should basically go all the way to Medicare Advantage and we should have a competitive mechanism. Or should we? And that's what we'll talk about next time, which is thinking about the pros and cons of choice in health insurance markets. Okay, let's stop there. And we will come back. Problems That Going Out Friday is due in 2 weeks because there's no section next Friday. And we'll come back and continue to talk about healthcare on Monday.